NUCD 2022. And today we have to discuss a very important thing with one of the best frontline practitioner, academician of the country, Dr. Manoj Chawla. And we are going to discuss about pre-diabetes and metformin. As we know, diabetes epidemic with 537 million diabetics between the age of 20 to 79 are there in the world. And for every known case, there is an unknown case. And as we know, there is another group of people whom we say pre-diabetic are almost 541 millions. So Dr. Chawla, what is this pre-diabetes?
Good evening, Dr. Kanungo and everyone here, and pleasure for being again at NUCD. A very, very valid discussion and topic, and I must congratulate you because it's not very often that people are talking about pre-diabetes as much. And to get directly dive into the question that you asked, what is pre-diabetes? So pre-diabetes is nothing but pre-diagnosis of diabetes. It's actually a warning sign of things to come. It is actually a condition which should not be viewed as a clinical entity, but rather as a condition which has increased risk for developing diabetes and cardiovascular disease. We need to understand that by the time a person develops clinical diabetes, almost 50 to 60% of the beta cell to clinical diabetes start several years before one develops diabetes. That entire period of worsening and increasing insulin resistance, declining beta cell function, with some increase in the numbers is what is called as pre-diabetes. So again, I repeat, it is pre-diagnosis of diabetes, what is referred to as pre-diabetes.
So it brings a very important question. How do you diagnose pre-diabetes?
Of course, yes. So a very valid question again, that how do you diagnose pre-diabetes? Now, if you go by the numbers, and there are the criterion laid down, for the ADA criteria for the same would be to look at the fasting sugars, the 2 hours post glucose or 2 hours postprandial, and also the HbA1c values. So there are actually 3 parameters which can help us pick up individuals with pre-diabetes. When we say impaired glucose tolerance, it means those individuals whose postprandial or post-glucose, essentially it is the post 75 grams glucose sugar, which lies between 140 to 199, are individuals who belong to impaired glucose tolerance as long as their fasting sugar is normal and less than 125. However, there is another aspect to pre-diabetes, and that is impaired fasting glucose, wherein the fasting blood sugar lies anywhere between 100 to 125. Those individuals will be labeled as impaired fasting glucose as long as their postprandial glucose lies less than 140. And then HbA1c has also evolved as a wonderful tool to pick up individuals with pre-diabetes, and in fact gaining more popularity worldwide, which is an HbA1c value between 5.7 to 6.4 is looked as pre-diabetes. Less than 5.6 is considered normal, and of course 6.5 and above is considered as diabetes.
This is very important. So once we do the routine glycosylated hemoglobin test and it is between 5.7 to 6.4, we should strongly suspect that the person is having pre-diabetes. And do people call it in any other name, any terminology for pre-diabetes?
Well, actually, yes. So as I said, there are different terminologies in literature, and interesting that you should ask that, because the ADA calls it pre-diabetes. The WHO actually for the long time has referred to it as intermediate hyperglycemia. And if you look at the IDF literature, the IDF, the International Diabetes Federation, refers to it as impaired glucose tolerance. So pre-diabetes Borderline diabetes will be more colloquial, but pre-diabetes, intermediate hyperglycemia, and impaired glucose tolerance are the terms referring to pre-diabetes.
In India, what in by your estimate, how many percentage of people or how many numbers will be there with pre-diabetes?
So,
because that will be a very major problem for our revenue planning, health planning, and everything.
True, Dr. Kanungo, sir. And actually, rather than me just speculating and thinking, there have been some data which has been looked upon. In fact, the ICMR in-diet population-based study by Dr. Anjana Mohan and others, when they published this paper, they looked at the prevalence of pre-diabetes in about 15 states in India. And they found that the percentage of the prevalence of pre-diabetes was anywhere between 7 to 15% across the different states. In fact, when they looked at the northeastern states also, within the northeast, again, you had some states which were 7% and some going as high to 15%. So in general, we would believe that the prevalence of pre-diabetes is actually as much as the prevalence of diabetes today, and hence a huge scope, a huge window of opportunity for us to pick up these individuals, to screen the population, find out who may be in that susceptible population, in that pre-diabetes population, and try and do whatever is possible to prevent the progression from pre-diabetes to diabetes.
Right. So this here, once we know the situation, we have a scope to prevent diabetes in this group of population, or try for DPP, diabetes prevention programs, and so on. You know, as per your statement, people develop pre-diabetes, then go to diabetes. Is there any risk factor? Who are susceptible to develop from pre-diabetes to diabetes? What are the risk factors?
Right. So again, there have been classical risk factors which have been identified, and honestly, they're not very different from the same risk factors for the metabolic syndrome or risk factors for diabetes. So age, as the age progresses, the chance of pre-diabetes is going to be higher. There is a certain male sex preponderance for developing pre-diabetes. Obesity is a definite contributor again to increased chance of pre-diabetes. Comorbidities like hypertension are again very often predisposing an individual. So those with hypertension clearly should be screened on a routine basis for presence of any glucose intolerance. And then, of course, family history of diabetes. So family history diabetes, hypertension, obesity, male sex, increasing age would be some of the classical risk factors for developing pre-diabetes. And this would be similar whether it's in the urban or the rural areas. Having said that, Dr. Kanungo, I would again like to remind everyone that just as we speak about diabetes, there would be many out there who have no known risk factors and still land up developing diabetes purely because of the changing environment, the lifestyle, the financial prosperity, so to say, and the limited physical activity. And hence, even for pre-diabetes, there may not be risk factors. And that's why the general screening in the population today is so important, to pick up individuals in that zone who may be in pre-diabetes, where we can offer help early in the life of this person's pathological metabolic journey.
Absolutely correct. As Jocelyn told, that we are only observing the tip of the iceberg, and there is a huge lot inside that hidden for us to discover. Now the question comes, is this pre-diabetes is a treatable condition, or only lifestyle will manage it, or what should do? We cannot say that you have pre-diabetes. We must give some solution. How do we treat it?
Of course, and I think that is the idea of picking up these individuals. So clearly today, the insulin resistance is an extremely strong contributor to development of pre-diabetes and diabetes. We also must remember here that pre-diabetes in itself has a link with increased occurrence of cardiovascular disease as compared to individuals with normal glucose tolerance. So the individuals with pre-diabetes itself should be treated to improve their glycemia. And of course, a lot needs to be done to prevent the progression from pre-diabetes to diabetes. On an average, about 20 to 30% patients over a period of 2 years would move from pre-diabetes to diabetes. Of course, there would be different epidemiological data from across the world, some putting it at a higher figure, some putting it lesser, but this is the average that I'm speaking. So help needs to be offered here, and that management and help comes in form of both the lifestyle change that we can induce or we can encourage in our pre-diabetes individuals, and then there has been some evidence with the therapies as well when it comes to what has been seen in the studies and what can be done with different drugs, where we've seen some success in preventing the progression from pre-diabetes to diabetes.
Which drug do you mean commonly available? Do you mean
So,
metformin?
well, yes. So metformin is the number one drug when it comes to what has been maximum evidence for using in individuals with pre-diabetes. But let me take a step back here and say that when you're talking about the lifestyle change, what exactly are we trying at pre-diabetes? So from the lifestyle modification point of view, we are essentially looking at a 5 to 10%, on an average, a 7% weight loss that individuals with pre-diabetes can achieve, and moderate physical activity, which could be defined as about 150 minutes of walk per week. These two habits, if we are able to achieve, that has an extremely helpful impact in prevention of worsening or progression from pre-diabetes to diabetes. In terms of drugs, there have been some drugs which have been tried in the different trials. To name a few, we've had maximum evidence for metformin, as you rightly mentioned. There has been some data for drugs like the alpha glucosidase inhibitors, both for acarbose. We had the stop NIDDM trial, and then there has been some data from voglibose. And then you had liraglutide also used in this segment with some limited success. The one drug which was also tried and didn't show in the Navigator trial, I think, was nataglinide, which did not show much help in the pre-diabetes to diabetes. But coming back to metformin, that is the drug in consideration and clear recommendations for that in the pre-diabetes group.
Do you have any evidence? Our clinicians or diabetologists would like to know, why should they use metformin for pre-diabetics? What is the evidence for metformin in the use of pre-diabetic patients?
So, yes. So I think everything needs to have substantial evidence for it to be accepted and used. So one of the biggest trials, as you also mentioned, for metformin was the diabetes prevention program in the US. So this was a study which was done in individuals with pre-diabetes. This was across, I think, 27 centers in the US. And they used metformin in a reasonably high strength. This was 850 milligram twice a day, which they used in patients across the study for 3 years. And then you had follow-up periods. In fact, you had a follow-up period for these individuals at the end of 10 years and then an extension at the end of 15 years. So the largest study to date, even if you look at the primary period of 2.7 years, has been the diabetes prevention program, which showed that the intensive lifestyle modification was the plan in that trial, scored the best in terms of prevention from pre-diabetes to diabetes. And this was followed by metformin. So metformin was close to 27, 28%, and the lifestyle change was closer to 40%. So, if somebody can pursue intensive lifestyle modification, probably that's the best. But where it cannot be intense, there is, moderate or minimal lifestyle change. Then with metformin, there is great evidence to prevent the progression to diabetes. In fact, there have been some other smaller studies. Amongst the more recognized studies is the Indian Diabetes Prevention Program, which was published way back in 2006, which was by Dr. Ramchandran and group. And they showed that when in the pre-diabetes segment, they use metformin. In fact, they use smaller dose of metformin with moderate lifestyle changes up to 500 milligram per day. Most patients in that trial were on, in fact, 250 mg of metformin twice a day. And they saw reduction in the progression. Of course, the percentage was lesser. They didn't see the high percentage like in the DPP US. They saw somewhere close to 7 to 10% absolute reduction in progression from pre-diabetes to diabetes. But what they could show was this was achieved by smaller dose of metformin, and in the Indian patients, the lifestyle modification was scoring the same as the low dose metformin. So again, good evidence there for that from the Indian data itself.
Patients think, and even clinicians think, that by giving a metformin product, there may be drug, can be hypoglycemia or any other complication, gastritis and all that. What do you think about that?
So, well, first we need to clearly appreciate the fact that metformin is probably the best insulin sensitizer that we have till date. Metformin essentially works by reducing the hepatic glucose output, which is responsible for the fasting hyperglycemia. So the gluconeogenesis, the glycogenolysis, these two aspects is what really metformin is blocking. And besides that, having its impact on improving the insulin sensitivity at the level of muscle and fat. Metformin does not have an impact on the pancreatic beta cell function. Unlike a sulfonylurea or other so-called oral hypoglycemic drugs, metformin is an anti-diabetic drug. It's an insulin sensitizer, but not a hypoglycemic drug. So metformin does not cause hypoglycemia. Yes, there would be those very, very rare couple of cases in literature documented from across the globe of metformin-induced hypoglycemia, but extremely rare. So very safe drug. Today, this is used for individuals with pre-diabetes. It is used for young women with polycystic ovarian syndrome as one of the better drugs for, again, reversing insulin resistance. Extremely safe. These GI side effects are a limitation. The possibility of gastritis, certain diarrhea, certain irritations can be experienced by some individuals, especially in the first few weeks, and then settles down. A higher dose of metformin may again cause some impact for few individuals, where we may have to bring down the dose of metformin, but yet remains amongst the safest medication or drug for patients with diabetes and also with pre-diabetes.
So, Dr. Chawla, it is pleasure talking to you. And as you have established that pre-diabetics is rampant and lifestyle modification is one of the primary goal, and metformin has a definite role in treating pre-diabetic cases, those who are between 5.7 to 6.4 glycosylated hemoglobin. What will be your message to our clinicians, those who are hearing us?
So I will just say that, just remember that there are recommendations by the ADA, EST, and by the RSSDI group as well. Metformin to be considered in the use for patients with pre-diabetes. What you have to remember, what they're saying is, for those, especially with a BMI of more than 35, I will bring that cutoff down in the Indian subjects to about 32. Those who have an age of less than 60, there's better evidence. So those with the BMI cutoff, those with I'm sorry, I'm losing those with the BMI cutoff, those with the age cutoff. These are the individuals where metformin should be preferred in patients with pre-diabetes. My message is, start screening the population, pick up more individuals with pre-diabetes. You can both use intensive lifestyle with or without metformin as you feel necessary, but that's a window of opportunity to prevent long-term complications and delay the progression from pre-diabetes to diabetes. Let's not ignore pre-diabetes. Let's keep it in our minds when we are treating our patients out there.
Thank you so much. It is pleasure talking to you. See you in the panel discussion.
Sure. Thank you, sir. See you.
Thank you.